It's good to be with you. And I want to talk tonight about the most important health problem the world is facing and has faced. And it's a good news, bad news situation. I'm going to start with some cartoons. So this is my conflict of interest statement. There I am next to Joe Camel. Anybody know where this is from? It's from Petra, Jordan. If you get a chance, you should see it. I should say that our center where I work has a relationship with Pfizer, which makes smoking cessation drugs, but we don't get any compensation for that, so I don't have any fiscal conflict of interest. The next slide is just calls to our attention that it's been 52 years now since the report of the Surgeon General in 1964 that made the historic linkage, which officially blessed the link between smoking and getting lung cancer. And that really began the decline of smoking, with a decline which has taken far too long. This was an issue of the Journal of the American Medical Association that was published to commemorate those 50 years. And there's a nice montage of people. This is Luther Terry, who was a Surgeon General at the time. There's Bogart, and there's a woman who was very disfigured from her smoking. And so if you get a chance to read this, it would be interesting. And then the final talks about when CVS stopped smoking cigarettes and the Marlboro man rides off into the dust. So I'm old enough, and some of you may be too, to remember the following things. When ashtrays were out in every home, actually when we got married, we had a number of very fine ashtrays that were given to us as wedding gifts. We haven't used them in 30 years. When you can smoke in airplanes, and then they did a silly thing. They said, well, we only smoke in half of the airplanes, as if there was a wall that the smoke couldn't go through. And then I remember the Camel News Hour. Nurses, where I trained, and where a colleague here trained too at the same hospital, they would take smoke breaks. You would go into the patient's bathroom and see people smoking. And finally, many of our colleagues smoke. So I'm going to take a little poll here. For those over 50, how many of you, your parents smoked? For those under 50, how many of you, your grandparents smoked? So virtually every hand in the room has gone up. How many of you smoked in college? A few hands. How many of you who are over 50 have children who smoke? Nobody. And that basically summarizes a very important social trend in this country. So if that's such a big deal, why am I here talking about it? Because it's still a problem. So I work at the Smoking Cessation Leadership at UCSF and have been running that program since 2003. We only work in the United States because our funders are not able to work overseas, but there are huge problems overseas, as I'm going to show you. There are 6 of us plus me. We're located at the Laurel Heights campus at UCSF, and we have multiple programs, partners, and deeds. And if there's time at the Q&A, I can talk about our center, but I'm going to plunge now into the content and cover these 5 things. Facts about smoking and health, the epidemiology of smoking, policies that have helped to slow and then lower the rates of smoking, how to quit smoking, and then sort of an update on new things, including, because I know you're all curious, the e-cigarette. So that's going to come later. So facts. About 540,000 deaths a year in the United States from smoking. 540,000 deaths. A huge amount. You know, when we had SARS, or we've got Zika, or you had other things, it's just, and yet it happens every day, and so we've kind of gotten used to it. About 6 million deaths worldwide, and that number is going to grow mainly because of other countries, particularly Asia and the former Soviet Union. Of those 540,000 deaths, about 41,000 are exposure to secondhand smoke. So these are people who themselves don't smoke, but they're exposed to someone else's smoke, and they get either emphysema or lung cancer or heart disease. About 14 million people in the United States are seriously ill from smoking, in addition, of course, to the 540,000 deaths a year. Many of them, of course, turn into that statistic. and about 60% of those have chronic obstructive pulmonary disease, emphysema. You see them carrying oxygen tanks. These are people who cough a lot. And we have about 40 million smokers in the United States today. So these are data that are somewhat old, but the kind of proportion is the same. These are behavioral causes of annual deaths in the United States from various personal behaviors. So this would be HIV mainly. This would be drunk driving, liver disease, car accidents, homicide, drug-induced. You notice we have two figures here. In 2004, JAMA published an article saying, oh my gosh, the obesity epidemic is running rampant, and it's going to eclipse smoking as the #1 cause of illness. And the New York Times ran a front page coverage on it. It turns out they calculated it wrong. They assumed that overweight older people were really at risk in a way that they're not. So they revised it down all the way to 112,000. It's still #2, but it's nowhere near this previous figure. The other thing I want to point out is this white line, which says that of the then 435,000 deaths, remember now it's 540, about 200,000 occur in people with mental illness or substance use disorders, that is, people who abuse alcohol, heroin, cocaine, something else like that. How do people who smoke and die? Why do they die? Well, they die from heart disease, from lung cancer, from respiratory diseases, from secondhand smoke, and the number at this point was a little bit higher, actually, because the prevalence of smoking is less now. Cancers other than lung and others. And so you see it's an equal opportunity killer. And this is one of my favorite slides. It's a synopsis of all the damage that smoking causes. And every year new papers come out and I add in yellow new things. So I'm not going to, I'll give you a moment to just read these. The first column is cancers. Of course, lung cancer is by far the leading cause of cancer caused by smoking. Prostate was recently added. Smoking doesn't cause prostate cancer, but if you're a smoker who has prostate cancer, you're not going to live as long as someone who has prostate cancer and doesn't smoke. Pulmonary disease, we recently added TB. Type 2 diabetes mellitus, which isn't a cardiovascular disease but can cause it. Childhood obesity, if the mother smokes. Childhood schizophrenia. And of particular note, a lot of people, rightly so, and it's in our family, worry about getting Alzheimer's. Turns out that Alzheimer's is a mixed bag. There's some cerebrovascular disease, as well as the characteristic plaques in the Alzheimer's brain. And if you smoke, you're much more liable to get the cerebrovascular component of Alzheimer's. So smokers have an increased risk of getting Alzheimer's disease. So quitting helps in a lot of different ways. And this is a complicated slide, and I'll walk you through it. Within a couple of weeks, circulation gets better, walking gets better, and your lung function's better. There are little things called cilia in the tracheal and bronchial passages, which are little tiny hairs, which sort of do hygiene. They sweep up the mucus and all the kind of bacteria and the viruses. They're killed by smoking. They grow back. And there's also many more mucus glands in smokers. So you sometimes see that someone stops smoking, they actually cough more because the cilia are back and they're clearing out some of that, all the stuff that's been there. But this gets better. After a year, the risk of coronary heart disease decreases to half of that of your twin who keeps smoking. After 5 years, your risk of a stroke is reduced to that of someone who's never smoked. Lung cancer rate risk never goes down to 0, but it gets down after 10 years to half of that of a continuing smoker, as does the risk of other cancers. And after 15 years, your risk of getting coronary heart disease is similar to someone who has never smoked. So it's good to stop, and it's good at any year. And this just shows you the years of life gained if you stop smoking. Obviously, the earlier you stop, the better. Even if you're over 65 to 75, you'll gain a couple of years. And I've got a slide which I'm not showing you, showing the risk of getting lung cancer from a continuing smoker or someone who stopped. and the risk goes up even to age 90. So there aren't many smokers who live to age 90, but those who do are more risk of getting lung cancer. So over time, my story of the fact that we got wedding gifts of ashtrays and don't ever use them kind of reflects, and also the poll that we took here tonight, reflects the fact that in my parents' generation, and my parents were born at the beginning part of the 20th century, smoking was sort of a classless habit. That is, people who were wealthy and educated smoked at about the same rates as other people. Nowadays, that's not true. Smoking has become a population of vulnerable people, and I'm going to spend some time talking about that. And in a sense, smoking has become a social justice issue. So individuals with mental illness or substance use disorders, I should mention here, I'm going to show you later, that the overall rate of smoking now is at an all-time low of 15% of adults. Amazing, really good. But individuals with mental illness or substance use disorders have a rate of about 38%. The poor, below the poverty level, 29%. Less educated, I'm going to come back to that. LGBT persons, we're not exactly sure why, but apparently there are stressors from having that kind of a life and the stigma that's kind of attached to it. And so smoking is both a part of the culture and is also a way to lower tensions. The homeless have a huge rate of smoking, and people in prisons. Now, many people in prison are not able to smoke, but they start smoking as soon as they're out. Secondhand smoke, remember, it causes anywhere from 41 to 50,000 deaths a year out of that 540,000. And these are the things that happen when you're exposed to secondhand smoke. In the developmental way, it's the most common cause of premature birth, common cause of sudden infant death syndrome, premature delivery, as I mentioned. Kids of parents who smoked are more likely to get a depression. Bruxism means teeth grinding. I don't know how they found that out. And other things. So again, cardiovascular is probably the #1 reason why people exposed to secondhand smoke die, because the curve is very steep. It only takes a little bit of exposure to smoke to make the platelets in your blood more sticky and to predispose you to a blood clot. So that's the problem there. Now, a lot of people, I won't take a poll, but a lot of people think that it's the nicotine that gives you cancer. It's not the nicotine. It's all this other stuff. There are 7,000 components in tobacco smoke, including 69 that are proven to cause cancer, a whole lot of other stuff. The nicotine gets you hooked, makes it harder to quit, but it isn't what causes you to get cancer or to get lung disease or to get heart disease. So that's what smoking does to you. Now we're going to turn to who smokes. And this is a picture of the world. And this article was in that issue of JMA that I showed you the cover with Bogart in it. So the proportion of adults who smoke have actually declined worldwide from 41% to 31% in men, and from 11% to 6% in women. In many countries, there's a real social stigma to women smoking. The Arab countries, the Asian countries, not European countries, not here. But overall, the number of smokers in the world rose from 718 million to almost 1 billion because the population climbed a lot faster than the prevalence of smoking declined. There are some countries where more than half the men smoke, Russia and Indonesia, and some countries where more than 30% of the women smoke, Greece, Romania. We hear a lot of bad things about how the United States performs in health and healthcare. One of the ways we've done really well, we're one of only 6 nations in this period that had a greater than 50% decline in the rate of smoking. So let's hear it for the US, at least in that area. And this is an amazing slide, I think. Some of you may be old enough to recall an advertising campaign in here. Remember what that was called? You've come a long way, baby. Virginia Slims emancipated women, and what I like to say is women who smoke like men die like men who smoke. And that's what happened. So that gap got really narrowed. There's still a little bit of a gender gap, but not much. As I mentioned, 15.1% of people are smokers. Now, it used to be thought, wow, well, if the smoking rate goes down, the people left smoking are really the hardcore people. If that were so, you'd expect that the number of cigarettes smoked per day by the remaining smokers would have gone up. In fact, that didn't happen. So the number of cigarettes smoked per day by smokers stayed the same until about 95 at a pack a day. By the way, I had a couple of students at UCSF ask me, Dr. Schroeder, how many cigarettes are in a pack? It's become that foreign to young people. It's pretty amazing. The answer is, of course, 20. And so they were smoking a pack a day, and then this began to go down. So now the average smoker, not only is the smoking rate going down, but the average number of cigarettes by those who continue to smoke is down here. And there's a sizable proportion of smokers who only smoke weekends or intermittently, which lowers their risk for lung cancer, but not necessarily for heart disease. So again, I'm going to go through the populations that smoke. So the overall rate, 15%, men more than women, age-related, very few people over 65 smoke. That's a function of two things. One is a lot of them have quit voluntarily, and others, a lot of them have died. Poor people. GED is an alternative way of getting your diploma from high school. Anybody have a guess as to why the GED smoking rate is so high? Prison. A lot of people are in prison for drug and alcohol problems. They have high smoking rates. They haven't graduated from high school. They get their GED there. Doctors' smoking rates are about 1 to 1.5%. So you can see the better educated you are, the less you smoke. American Indians, Alaska Natives, almost 30%. Asians, 9.5%. An interesting phenomenon here. Asian men in places like China, Vietnam, Cambodia, Japan, have smoking rates of 40 to 50%, really high. Asian women, 3 to 4%. And yet in California and the rest of the United States, the smoking rate of Asian men is 15, 20%. It isn't that only non-smokers immigrate to the United States. It's that they perceive smoking isn't cool. And when they come to the United States, they want to blend in. In China, where I once was on some smoking stuff, you greet someone by offering them a cigarette. When's the last time you saw that happen here? You probably haven't, right? Blacks, 17.5%. Hispanics, 11%. Whites, slightly higher than blacks. Multiple race here. Huge regional differences. California has the second lowest rate of smoking. If you adjust for the Mormon percentage, which is about 50% here, we're actually number 1 if you do that kind of an adjustment, but the demographers don't count that. And you notice this belt here, and this next slide is one of the most kind of dramatic and tragic slides that I show. Isn't that amazing? It just makes the graphic linkage between smoking and lung cancer. So trends in smoking prevalence among children, youth, ever smoked in the last 30 days, a remarkable decline, 36% to 13.6. Do you smoke daily? 24.6 to 6.7. Do you smoke at least a half pack a day? 14.3 to 2.6. So real progress in this, which is encouraging. In fact, more kids are using dope today than are smoking cigarettes. And some studies show that they think that it's more harmful to smoke cigarettes than to smoke dope. So I haven't dwelt on this, but there is a paradox that some of you may have seen. The smoking rate is going down, and yet the number of deaths are going up. How can that be? Well, that's a function of two things. One is scientists have gotten better at teasing out that smoking kills more people than they previously thought. And there's a lag time in lung cancer about 30 years. So from the time, as the trends start going down, there will be a long time before the lung cancer deaths go down. And it's only recently that women's deaths from lung cancer have gone down. Men's lung cancer deaths have been going down for quite some time. So how have we achieved these declines, which people have said is the public health triumph of the 20th century? Again, it's good news, bad news. The bad news is all the carnage it's still wreaking. The good news is how many fewer people are smoking and getting ill from it. So this is a sort of a quick tour. There's a federal excise tax. I'm going to show you what that is soon. The report of the Surgeon General, which you saw. TV ads banned in 1970. This is dancing. Let me see if I can. I guess it's going to keep dancing, all right? It's a swinging presentation. Between 1973, starting in California, and really as a model for the world, localities began to make places smoke-free. And I believe the first city was Lodi, California, and then it was Berkeley and San Francisco and others. And the Congress has, because the industry is so powerful, the Congress has been trying to prevent the military and the VAs from stopping selling cigarettes. And so that's been a long-term sort of a battle. In 1990, smoking was banned in all airlines. Hillary Clinton in 1997 banned smoking first in 1993 in the White House, and then President Clinton banned smoking in all federal buildings in 97. The attorneys general sued the 5 largest tobacco companies to recoup the damages paid by state Medicaid programs for caring for people with tobacco-induced illnesses. And the tobacco companies settled for $209 billion, which were given to the states. Unfortunately, they didn't use them much on public health. They used them on prisons and highways and things like that. But it had a nice side effect, and it wound up raising the price of a pack of cigarette because the tobacco companies wanted to regain the money that they had lost. Mayor Bloomberg famously banned smoking in New York City bars and restaurants. Other cities had done it previously, but the Big Apple is still the Big Apple. There was a national quit line that anybody in any state in any city can dial 100 quit now and get connected to a local telephone quit line. And I'm going to come back and tell you more about that. The FDA was given authority to regulate tobacco, but hasn't done much yet. They were going to put gross warning label pictures on a pack of cigarettes. Someone smoking through a trachea, someone dead, someone a premature infant, but a local court in Washington said there's no evidence that works and it's an infringement on free speech, so they're back to the drawing board. All these actions I showed you were spurred by scientific evidence about smoking and health. So the science had to come first, and places like Stanford and UCSF and other places were at the forefront of that. Evidence about the dangers of secondhand smoke, so that the 75% and 80% of people who didn't smoke were concerned about people who did smoke because they didn't want to harm their own health. Evidence of the duplicity of the tobacco industry. They lied, they bullied, they faked data, they did a lot of bad things, and the progressive denormalization of smoking. So that's how progress takes place. So in that same issue of JAMA in 2014, they summarize the benefits of all those things. During this period of almost 40 years, almost 50 years, there were 17.7 million people in the United States who, I should have had a million in there, who died from smoking, but 8 million more would have died had the smoking rate stayed where they were in 1964. So an incredible progress. I mean, we were proud of polio vaccines and other things, but this is amazing. Preventing smoking-related deaths accounted for 30% of the life expectancy gains during that period. A huge, huge gain. But people with mental illness or substance use disorders did not benefit nearly as much from those declines in smoking rates. So here are excise taxes. It may surprise you to know that California, although it's second lowest state in the country with smoking rates, its price of a pack of cigarettes, its state tax is only 87 cents. And we're number 37. Now, you know that there's a ballot proposition, Proposition 56, which has asked for a $2 a pack increase. I've already seen the the ads by the industry, which make a clever point. They say only 13% of that $2 is going to help smokers quit. What they don't say is the others are going to do things like fund primary care physicians, help to defray the costs of state Medicaid, and those kinds of things. So we'll see what happens. There was a similar kind of a proposal in 2012, I think it was, which lost 50.1% to 49.9. So we'll see. And this just shows you the trends in, here's the trend in the federal tax. President Obama signed the expansion of this children's health insurance program in 2009, which took the tax from the federal tax from 39 cents to $1.01. That was the biggest jump. And states really vary all over the map, as you can see. Some of them are much higher than others. And these are 4 states. California was one of the first states to pass a tobacco tax, but as you can see, we're now less than Oregon or Texas, if you can believe that, or the Empire State. So states tax, they get a lot of money from selling cigarettes. What do they do with that? Well, the average state tax has gone up. States are mainly now doing this as a revenue tax. And because the smokers are not very powerful politically, the only opposition comes from the smoking industry, the Philip Morrises and the R.J. Reynolds of the world. They're pretty much able, even in very conservative states, to pass a tobacco tax, but then they cut at the same time the budget for public health and for smoking stuff because there aren't many constituents to claim for that. And so this is a scandalous tally sheet. The states this was I think in 2012, got $25 billion a year from revenue from cigarettes. The feds got $15 billion. The industry spends about $10.5 billion in 2008. The CDC recommends that $3.7 billion be spent, and the state tobacco budgets are only $0.5 billion. And why is this? Because smokers and people who care about smoking essentially don't have much power politically. So women who get breast cancer it's a tragedy, and they mobilize, and particularly middle-class women. There's a race for the cure, there's a pink ribbon. Probably most of you don't know that more women die of lung cancer than of breast cancer. Plus, there's all those men who die of lung cancer. And yet, because research priorities are often political, this is how much is spent on breast cancer, and this is how much is spent on lung cancer. And these are the various places that fund it. The biggest source is the NIH. There is no race for the cure. There is no brown ribbon. This is a function of several things. One is that women who die of lung cancer tend to be poor. They tend to be stigmatized. And women who get lung cancer die. And most women who get breast cancer live. And so the lobbying balance is disproportionate. And this just really states that. So this is, I'm not a techie, I'm not a quant here in Silicon Valley, but this is a formula that's pretty easy to know. The number of smokers is a function of the number of new smokers, plus, and that's almost always before the age of about 25. Very few smokers start after 25, About 85% of them start by the time that they're 18. Plus the people who continue to smoke minus the quitters. And there's two ways you quit, voluntarily or going out in a pine box. So how do you quit voluntarily? Well, price sensitivity. So raising the taxes on a pack of cigarettes is a dissuasion. Clean indoor air laws, particularly if you're working in a building on the 30th floor and you can't smoke in that building, and most buildings now are smoke-free, you got to get your purse and go to the elevator and go down the 30 floors. Hopefully you'll get a fast elevator, you might not. Go out and smoke, and it's New York or Philadelphia in the middle of the winter, and the wind is howling, and this is the wretched people furtively smoking. Then you finish your cigarette and go back up again. Your coworkers are scowling at you. So it's a big incentive to quit clean indoor air. Counter-marketing, places like the Truth Campaign or the state. Some of you may have seen some of the state advertisements here in California. The advice of a clinician will both increase the quit attempts and then the probability that that quit attempt will win. Now, 70% of smokers want to quit, and probably 50% of them try in any 1 year. But ultimately, it takes you 10 to 12 attempts before you're able to quit. And there are now more ex-smokers in the United States than there are current smokers. So medications, counseling, and the advice from a clinician, especially a doctor, is helpful. So let's move on to some clinical issues about smoking. This is a paper that we did, and it was an older survey, and I think the numbers are now down for doctors close to 1%. Nurses have had a remarkable plummet in smoking rates. They used to smoke actually at higher than the population, and now they have a rate lower than the population. Dentists, dental hygienists, pharmacists all have very low rates, as they should. So what tobacco dependence is a two-part problem. The addiction to the nicotine, I'm going to show you a little cartoon of how the brain works there, and then the behavior, the cues. So a lot of people who are only occasional smokers in states where you can smoke in bars, which you can't in California, they go to a bar and they smoke because all their buddies are smoking there. And then the rest of the week they don't smoke. So it's both of these, and you got to treat them both. Nicotine is, so the cigarette is a delivery device for the nicotine. You take a puff, within 11 seconds, nicotine is in your brain. Amazing, and it settles on the nicotine receptor in the brain because it goes up through the arteries. There you are. And this is the cartoon. So the nicotine comes up through the arteries. It lands on nicotine receptor sites in these two areas of the midbrain, releases dopamine, which is a brain chemical, goes to the prefrontal cortex, and it makes you feel good. The release of dopamine makes you feel good. Dopamine is released when you drink alcohol, when you do cocaine, when you do heroin, when you have sex, and in my case, when I hear Beethoven. And so it's very seductive to get that. And this is why when you stop smoking and you don't get this, the brain says, give me more. And it's why you get withdrawal. And it's why if you've been around people who've tried to stop smoking, they're not very pleasant. They're edgy, they bark, they're fidgety, they don't sleep well. Fortunately, that's not a continuous thing. So smokers smoke, at least regular smokers, to maintain the nicotine level in this area. And when they go to sleep, of course, they're not smoking, and the blood level of the nicotine goes down. And this is why a heavy smoker, one of the first things they do in the morning is reach for that pack of cigarettes. So there's one question, if you have a friend who's a smoker and you want to gauge how intensively they smoke, ask them when they smoke their first cigarette. And if it's 5 in the afternoon, you have a lot better chance to get aim to quit than if it's, boy, the first thing I do is I reach for a smoke. So there are, in addition to counseling, which really works, there are 7 different ways that you can take medicines to help you smoke. 5 of them are forms of replacing the nicotine that's in a cigarette. The gum, the patch, the lozenge, a spray, and an inhaler. Then there's a partial nicotine receptor agonist. So they designed a molecule that fits in that brain spot, and it gives you a weak effect, but it also blocks the high you get when you smoke. And that is called varenicline. There's another drug that you can get in Poland and in Australia. It's called Cessation. It's made from a plant leaf. Unfortunately, or fortunately, it's off patent now. So you can't get it in the United States because it isn't very profitable. My hope is that some generic company will do that because it's a lot cheaper than the other drugs. It seems to work very well. And then this is an antidepressant that was shown sort of in a serendipitous way. People who were getting that drug to treat their clinical depression, people noticed they were smoking less. And it takes away the craving. So those are the 7 drugs. And this is a complicated slide. I'm going to do a couple of prefaces for it. One is that in clinical trials, you get motivated people to sign up, people who are really interested in quitting smoking, not just the average smoker. So you can get higher than usual quit rates. Second thing that happens is that in the placebo groups, which are in blue, you get state-of-the-art counseling, more than probably in the real world. So this shows you that in the placebo groups, the rate of quitting smoking was about 10%. In the real world, the rate of quitting smoking is probably 3 or 4%. And when you add counseling plus these different drugs, you get different rates. This is probably the best. There was concern here that if you use varenicline and you were clinically depressed, you might have a higher rate of suicide. There's a recent study that came out in the Lancet that looks like that's not true, but there's still some kind of controversy on this. So you notice that even in the best studies, almost 3/4 are still smoking. On the other hand, if you keep trying, you're much more liable to quit. So quit lines. What are tobacco quit lines? They are toll-free numbers you get in every state. In California, they're called 1-800-NO-BUTS. And I'm going to pass some out to folks. Give them to people you know who smoke and tell them that if they like to quit, they should call that number. And I've visited some of them, and they're staffed by excellent counselors, usually with a master's or bachelor in psychology, very empathetic. They give free sessions, and some of them offer nicotine replacement vouchers that you can cash in at a pharmacy, free. And they give success rates comparable to what you get in clinical settings, and smokers prefer them because you don't have to go downtown and park and get child care and all that. So it's really a good deal. They're very underused. The one in California is one of the best ones, but only 1% of smokers still call a quit line. The highest rate is, I think, in upstate Maine, where it's like 8%. This is the old version of the gold card. They just come out with a new version, which is the one that I passed out. And the CDC recently had something called the TIPS campaign, which were gritty TV ads from former smokers explaining how they were able to quit smoking. And it drove the numbers to the quit lines, more than doubled them. So when you combine a media outreach with the quit lines, you can get a good kind of result. So we're winding down here, and I want to talk a little bit about the e-cigarette. That's the question I get asked the most whenever anybody finds out what I do. So what is it? It's a device that uses a flint to aerosolize nicotine in a propylene glycol soluent. The cartridges contain about 20 milligrams of pure nicotine. We don't know how safe they are. I'm going to come back to that on the next slide. But they're clearly a lot safer than a combustible cigarette, because instead of 7,000 chemicals, they've got 2 to 20, maybe. It depends on the flavor that have been used. Some people use them as a bridge to smoke to get their hit of the nicotine when they're not able to smoke in a social setting. Others use them as the experimental. And some people are worried that kids who are flocking to them are going to use them as a starter product and then become hooked on regular cigarettes. They probably deliver less nicotine than they promised. They're not approved by the FDA to help people stop smoking. And my advice is there are other ways to quit. But I'm going to give you a more nuanced, just sort of the Schroeder version. We're now in the third generation of e-cigarettes. And so many of the information that you get on the toxicity or the potency of e-cigarettes is archaic now, because it's on first or second generation ones. So it's a product that's really in evolution, and we're not quite sure where it's going to wind up. The data on whether it helps you to quit smoking or prevents you from quitting is unclear. My ballpark guess is that about 15% of smokers who try the e-cigarette are able to quit, and the rest of them are what they call dual users. They're much, much safer than a combustible cigarette. The good Lord didn't want you to inhale smoke from a leaf, whether it's pot or whether it's a Marlboro. And the Brits have estimated that they're about 95% safer than a combustible cigarette. There's a fierce debate in the United States between some people who say this is a way to get people off a combustible cigarette, and it's much better than doing that, and others are saying it's a stalking horse, it's the industry, it's bad. And so this 5% has been argued, but no one is saying that they're any more than, say, 15% as risky as a regular cigarette. And the Brits have really looked at the data, and this is their ballpark estimate. Are they as safe as room air? No. So you don't want to be next to a vapor, that's what they call them, but you don't do that. Secondhand exposure is much less dangerous than regular cigarettes, but you don't want to do it. The marketing is predatory. So if you go into a vape shop, you should do that. There's some in San Francisco. I don't know if there are any in Palo Alto. But if you go into a vape shop, there's actually a sampling menu. You can get 10 different tokes of different flavors for $10. I looked at the menu. I didn't buy it, but I looked at it. And they make flavors like bubble gum and cherry. So they're clearly aiming at kids. The industry is in transition now. And it looks like the tobacco industry is buying up some of the smaller manufacturers. And so one can only shudder at what the marketing is going to be from that. And this is one reason why the people who don't like e-cigarettes are very, very nervous, as they should be. I've seen some data recently that shows that nicotine exposure to the adolescent brain, separate from smoking, just the pure product, is bad, and it puts you at risk for conduct problems later on, including acting out, including using other drugs. So you don't want your teenage kid or grandson to use the e-cigarette. So my ideal solution, and I don't know how you can get there, is to get all the 40 million smokers either to quit outright with the drugs and the counseling you mentioned, or to switch to the e-cigarette, but have no kids do it. It's hard to make that happen. And what about this evidence that they're a gateway? Well, this is what's happened. As the rate of smoking by young people has gone down, the rate of using the e-cigarette has gone up. If this is a gateway drug, then this should have come back up again. So there may be selective instances where young people use it as a gateway, but on a population level, it just isn't happening. And that's the people who are really fiercely anti-e-cigarettes don't have a good answer to this. So Kevin asked me to talk about the difference between the tobacco epidemic and the obesity epidemic, because that's the most recent epidemic that's jeopardizing public health, and people are saying that there may be, that at some point, this may be as big of a problem as smoking. So I have here a side-by-side in the next two slides of similarities and differences. So both of them, they're very common. They tend to begin in youth. You didn't know about them much in the 19th century because until you could mass manufacture cigarettes, or go to fast foods, you didn't have a lot of people overweight or smoking. Major health implications, yes. Heavy and influential industry promotion, yes. Inverse linkage to class, yes. That same belt with all the cancer deaths from lung cancer, this is where there's more strokes, there's more heart disease, and there's more people who are overweight. This, in translation, somewhat got moved, but there are major, the same kind of regional variations that I showed you are there. Stigma, it's a big stigma against smoking and against being overweight. Harder to treat, and doctors don't like treating it. Doctors, it's hard to get people to change their personal habits, and it's frustrating for doctors and other clinicians. So it's a difficult clinical situation. The definition is not relative for smoking. You either smoke or you don't smoke. Arnold Schwarzenegger would meet the body mass index definition of someone who's overweight because he's so bulky, and yet he's obviously not an obese person. So the definition is a little bit different. But you see here a lot of similarities. The next slide shows how they're really different. So you can stop smoking, you can't stop eating. There isn't any nicotine, although some people think that sugar really gets your taste sweetened and maybe changes the microbiome, the bacteria in your gut to make you crave sweets more. Harmful at low doses, cigarettes, yes. Being overweight, no. Behavior harms others. I've had an instance where secondhand fat has made me less happy. Middle seat of an airplane, cross-continental, two bulky people on either side spilling over into me. It makes for a very long flight, but I'm not sure it took years off my life. Maybe it did. The extent of the industry lying and all, there's predatory advertising. If you watch cartoon shows in the morning that the kids watch, they really do try to seduce the kids, but it's not nearly the way it is for smoking. History of suing the industry, not yet. Large cash settlements like the $209 billion only in tobacco. Evidence-based treatment. Really, the only good treatment for this is gastric surgery, which is pretty draconian. Economic incentives are in place, and I have here the New York Times from today, which is Thursday, August 25th, page 3, if you haven't seen it, showing data that when Berkeley passed its soda tax, and then people went back and did surveys, poor neighborhood kids were drinking 20% less soda and more water than in neighboring cities, which were San Francisco and Oakland. So this is a policy that could work. Philadelphia is probably going to pass a similar tax, so we'll see. And then a successful counter-marketing, like the Truth Campaign, we haven't done that yet. So there's a lot of hope that the obesity folks could learn from smoking, but I don't think it's as easy as people have fantasized. So what could you do? You could do the taxes. We now subsidize soy and corn and other things that go into high-energy sucrose. We don't give the subsidies to lettuce and tomato and fruit. So our agricultural policy is dominated for reasons of, obviously, politics in places like Iowa and Indiana. My guess is that's going to change at some point. Dianne Feinstein is trying to get that to change, hasn't been able to do it so far. A restriction on the use of food stamps, counter-marketing. The Pepsi and Coke did some really smart things. Public schools are cash-strapped, so they went to a lot of public schools and they said, can we put vending machines in the school and we'll pay you a lot to try to maintain those? And that trend is now going away, more so, I think, in wealthier districts than in poorer districts. Greater physical activity components at work, school, and community, and better treatment options. So, in the Malcolm Gladwell phrase, we may be at a social tipping point on smoking. California, prevalence of 11.7%. National prevalence at a modern low, haven't been this low since the 30s. Northern California, Kaiser Permanente, we worked with them. Turns out they didn't need our help very much. Drove their smoking rates down to 8.6%. CVS Caremark stopped selling cigarettes. Cigarette butt pollution is the new thing. It looks like beaches, you know, the cleaning up after butts is very costly. It also is a problem for fish, and so it may be that there'll be an extra tax to take care of the butts, which will drive the price up a little bit. Under the Affordable Care Act, insurance companies can now charge smokers a higher rate. I mentioned the 62 cent tax increase federally. Lung cancer deaths in women are finally falling. More and more stigmatization of smoking. That's a double-edged sword. I'm glad it's stigmatized. On the other hand, I have great sympathy for smokers who can't quit. And my counsel is hate the smoke, love the smoker. And then there are going to be mass media campaigns this year by 3 major federal agencies, the FDA, the Legacy Foundation, which is now called the Truth Initiative, and the CDC. So where are we in 2016? Most people in Washington or in Sacramento essentially live in a smoking-gated community. And I'll bet, like us, you haven't had a smoker in your house for a long time. And so we don't perceive it as a problem. And smoking is now marginalized to the poor, the disadvantaged, plus some young people who think they're not going to die of anything. These are the same people who ride a motorcycle without helmets. So smoking has essentially become a social justice issue. And it needs advocates because there are other fattier things that get advocates and these don't. There are new products and markets, e-cigarettes and marijuana. And the tobacco industry, meanwhile, is fighting as hard as it can to slow the rate of the decline of its domestic market while getting access to world markets. So it's exactly on the hour, and I think we'll open it up now for questions.
Okay, you want to hold?
Thank you.
You'll want to hold the mic about 3 fingers width so that it'll work effectively. And just raise your hand and Betsy will give you the microphone.
Steve, we were in Hood River, Oregon, a week or so ago, and we saw a street sign that said greenery, edibles, vapes, and dabs. So we went into the local dive shop selling not these things, but other things. And we asked the guy that sold us a paddleboard, what is dabs? And he said, oh, that's a kind of a distillate of marijuana. He said, that's, you use that, I don't particularly like it myself. And then he went on to describe all the various effects and side effects of the drugs. In states like Oregon, Washington, Colorado, what degree of overlap is it going to be between vaping, people using marijuana, and people vaping traditional cigarettes? What impact has been demonstrated, or do you anticipate?
So it's a great question. It's very topical. It's the Wild West, the overlap among smoking a regular cigarette, a marijuana cigarette, and vaping. The device that permits you to vape can permit you to smoke dope also. I'm astonished that there's not more policy worry about legalization of the marijuana, kids out there driving and all that. And I was at a meeting of legal people in the Northwest, folks from Colorado, Washington, Oregon, and they gave me an interesting answer. They said, politically, the left is so pro the marijuana that it's hard to be against it in these liberal states, which I thought was an interesting comment. The saving solution on health is that you don't get many people smoking a pack a day of marijuana. So these are people who do it on an intermittent basis. We've not had, the NIH has not been able to do any research on the health impact because it's not been a legal product. People haven't been able to get access to it. So a lot of us have been saying, let's loosen up the regs so people can study it. I don't want our grandchildren to be smoking dope. I don't want them to be smoking cigarettes either. But there's a tremendous impulse, and also there's a really worry because these are made as edibles and they're put in candy, so little 5-year-old kids are eating them. and getting sick. So I think it's just unfolding now, but clearly there is a sentiment, and I understand partly why, is that we have been unduly harsh probably in penalizing users and sellers. So Schroeder, we don't work on this, but my sense would be decriminalize it, but I'm not going to vote for the legalization of it in California. I don't think my vote's going to win, though.
Well, I can assure you your Palo Alto grandchildren are not smoking dope yet. I can't speak for the Oregon ones, though. My question for you is about the 5 other countries that have had similar successes to the US in terms of greater than 50% reduction in smoking. Are there parallels with what has happened in those countries and what we've done, and how are those, the successful countries, different from the ones that have not been as successful?
Sure. So how have the other countries done? So the other countries tend to be the English-speaking countries, Canada, Australia, and it's interesting that the United States has done it with minimal government action. So it's Tocqueville coming back again. It's been a bottom-up. In Australia, they have plain packaging now laws. So if you buy a pack of Marlboro, it's a brown cover. And Philip Morris tried to sue them, and the World Court said, no, no, Australia has a right to do this. Canada has garish warning lanes. So with those other countries, also in Australia, they have draconian drunk driving laws. So they stop people at 10 a.m. They do random stops on the highway. So there's much more of an assertive government role in Canada and Australia, New Zealand. In Sweden, they've used something called snus, which is smokeless tobacco in a pouch that they use. So they drove the smoking rate way down. The snus rate is way up. It appears to be relatively harmless. It may cause a little bit of oral cancer, but it's not a big deal. So we've done it our way, starting from the bottom up with local smoke-free ordinances, a sort of a citizenry outrage, a little bit like the barn building in Tocqueville in the 19th century. It's a great question. Okay, so how do our taxation rates? Our federal rate has been much lower. I think in Scandinavian countries, a pack of cigarettes costs something like $12. So most European countries have higher rates. In Asia, it's much lower. Asia presents a real challenge because it's so inculcated into the culture. It's mainly the men. In Japan now, it's starting to come down. China is the world's biggest exporter of tobacco. And one of the reasons that the southern states in the United States have not been as powerful in anti-tobacco laws is that most of the Philip Morris and the R.J. Reynolds products now are made from China grown, are made from tobacco grown in China. So it's really a complex issue. Other countries vary in their marketing. We probably do better in activating clinicians. We have the lowest physician smoking rate, I think, of any country. In Portugal, it's like 25%. Portugal. Chile, Argentina, 25% of physicians smoke. China recently was 40%. So I like to think, as a physician, we've modeled that and we've led the way. I'm not sure I'm giving us more credit than we really deserve, but I like to think so. I should say that last question was from the father of my grandchildren.
What if someone who smoked rolled their own cigarette just with tobacco? Is that as harmful as, I don't know, what's in a cigarette, different than just rolling tobacco?
So the question is, what's the harm of rolling your own cigarettes? One of the things that made the epidemic happen at the turn of the 20th century was when Buck Duke bought a patent to the automated making of a cigarette. If you watch someone roll their own cigarette, you can't roll 2 packs a day of a cigarette. So the major benefit is you just smoke less. But it's still the same bad stuff. And it's the lighting of it. It's the exposing the tobacco leaf contents, some of which are jazzed up by the companies that make cigarettes, and the paper, and then inhaling that into your lungs, which weren't meant to do that. Think of burning leaves and then standing over the pile of burning leaves and going, that's what smoking is. So the cigarette isn't less toxic, but you just smoke less of it. You also see advertisements for Natural brand and Spirit brand and all that. equally bad. And filters were advertised as being able to keep you from getting lung cancer. There's no evidence that a filter is any less harmful than a regular one, even though the filter itself turns brown.
Thank you. This is such great news. About 10 years ago, I did some work for the CDC and the World Health Organization evaluating marketing campaigns against encouraging youth not to start smoking and publicizing the adult cessation programs. I'm wondering, what we saw at the time was that just as soon as marketing programs became effective, budgets would get cut by state governments. I'm wondering if you think there needs to be a level of marketing, anti-tobacco marketing continuing to keep the rates as low as 15%.
That's a great question. What will it take? So it's known that counter-marketing is one of the successful strategies to get people to try to quit, to drive them to the quit lines, to do other things. And yet the budget for state tobacco control has gone down. And what happens is that as state tax revenues dried up, particularly after the bubble in 2009, everybody wanted to preserve their share. Tobacco advocates, or the people anti-tobacco, just don't have clout because they represent a constituency that doesn't donate, that's impotent, and everybody thinks, oh, cigarettes, that's history. And yet, as you saw, still 540,000 deaths a year. So you couldn't get that bill passed because the same people that carve up the budget are carving it up. How do you get extra money to do counter-marketing? Well, either raise taxes. Politicians don't want to do that. You take it away from roads or prisons or schools, and the claimants for those are much higher. So the public health people have to really fight hard to get that done. In Australia and Canada, the public health people have more power because government. The other thing that's interesting, I was giving a talk in Canada when the Clinton health plan failed, and they were asking me, why did it fail? And I had to tell the Canadians, you here in Canada, you trust your government. A lot of people in the United States, and this is how it was founded, it wasn't just in 1993, don't believe in their government. So there's not a lot of turn to the government to fix things. In fact, it's a staple of anti-political rhetoric.
So this is a more pharmacological question. I was trying to understand that when you smoke a cigarette, you said it takes 11 seconds for the effect in your brain. Is that the same with snus or chewable tobacco or other? Because it's absorbed by your mucosa. So what's the difference in the effect?
So is smoking as bad as chewing? Is that your
It's
question?
more like the effect in the brain. Is it within 11 seconds even for the snus or the chewable tobacco?
No. So the reason that when you smoke, the nicotine gets to your brain so fast is that it goes into your lung, which immediately gets vascularized. When you chew, it takes a little bit longer. And this is why, if you look at the uptake curve, putting on a nicotine patch or chewing the gum, it takes longer. But it still gets there pretty quickly. It maybe get there in a minute or two as opposed to the 17 seconds. So you don't have to wait, wait a long time.
All right. But then, sorry, this is another question, second part.
Sure.
So alcohol, when you consume alcohol or cocaine, you said the receptor pathways, dopamine receptor pathway is pretty much the same.
Yes.
But then when you have alcohol or marijuana or cocaine, you suddenly feel high, but you don't really get that buzz feeling with smoking immediately.
Okay. People differ, and some people think there's a genetic component that some people get a lot more pleasure, have genes that enhance the pleasure. I experimented a little bit with smoking when I was a teenager. I didn't much like it. I probably don't have that gene. Alcohol, small amounts, doesn't make you high. So in the nicotine, even a small hit can release the dopamine and people feel good about it. And the other thing that happens is chronic smokers increase the number of receptors for the nicotine in their brain. So I didn't show a slide, but there are some imaging slides that show here's the brain of a non-smoker with a few receptors for the nicotine. Here's the brain of a smoker with a lot more. And so that's why when you stop smoking, all those guys are saying, give me some more nicotine. So the question is, how long does it take to develop those extra receptors, and then how long does it take for them to sort of vanish? I don't think we really know. It doesn't happen overnight. Some people think that with kids it happens pretty fast, which is scary. And I had first heard that once you had all those nicotine receptors locked in, they never went away, but I've heard subsequently that there may be some evidence that they do sort of dry out, which would make it a lot more tolerable not to be smoking. These are all great questions, by the way.
I have a question. When you showed the cessation rates up there with the various methods for doing that, the best one was around 25%, which said 75% don't. And don't we in our society have an interesting but unfortunate little test going on? I've heard that of people going into prison, there's like an 80 or 85% smoking rate. And then in prison, there is no smoking. So literally they go from 85% of the population smoking to no smoking. Is there something to be learned from that process? Would that suggest that the other 75% is all behavioral? And how can you learn from that to actually improve cessation rates? Not that you should put people in prison, but is there something in that process to be learned?
So great question. When you put, most prisons now are smoke-free. And at first there was a lot of contraband and people were selling cigarettes for sexual favors and something, but there's not so much of that now. So most prisons actually, people don't smoke. And you're right, a high proportion of prisoners were smokers when they came in. A lot of them were in because of alcohol-linked or drug-linked problems. So they managed to tough it out. They don't have any choice. But boy, the minute they're out the door, boom, they're smoking again. Whether it's 1 week, 2 weeks, 5 weeks, 8 weeks, 2 months, 5 years, so they're smoking again. So if we were really draconian, I guess as a society, we could do that. But it's got to be a voluntary act to get long-term smoking cessation. Another great question.
The way you talked about the international rates, you sort of indicated that it was country by country. And I'm wondering if there's kind of an integrated effort by the World Health Organization, for example. It must be an enormous worldwide health problem. You hear about the WHO, which springs into action if there's some indication of a infectious disease. Some places they're not. A WHO effort that that's worldwide is aiming to try to reduce cigarette smoking.
So the observation is this is a worldwide program, a worldwide problem. The WHO, as the world body in charge of making health better, should be active in that. WHO has its hands full. It's the bureaucracy of WHO is difficult. They do now have a campaign saying that non-communicable diseases, heart disease, cancer, diabetes, are in fact replacing infectious diseases. Smoking is a component of that, but they've had difficulty putting that together into a coherent program. There are some philanthropists in the United States, namely Bloomberg and Gates, who have done programs in targeted countries. So Bloomberg has worked in China, Gates has worked in Africa. The rates of smoking in Africa are actually quite low, and they're going to try to prevent an epidemic happening there. India and China have the 2 highest rates of smoking, and Bloomberg is there, and they've worked through US groups at Johns Hopkins or Emory or elsewhere. So there is some effort there. It's interesting that when I was at the Robert Johnson Foundation, we tried to see if we could get Asian rich people to be involved with doing any philanthropy on smoking. Absolutely not. No interest at all.
Did they smoke?
Probably. It wasn't me making the ask. It was a group that we tasked to make the ask.